I am محمد أحمد, a pulmonary and critical care fellow at University of California, San Francisco. In my talk today, I will provide a quick review on ARDS, Acute Respiratory Distress Syndrome, as ARDS is one of the leading causes of death in patients who are infected with COVID-19. In my talk today, I will cover some of the statistics of ARDS in the era of ongoing pandemic of COVID-19, followed by a quick review of the most up-to-date definition of ARDS, and then I will spend most of my talk reviewing the evidence-based guidelines in managing patients with ARDS, which I will divide into mild to moderate disease, and then review the approach of refractory hypoxemia in ARDS. Although we have limited information still about the host innate immune response to COVID-19, but I found this review article very useful as it provides explanations, theories of the immunopathological response by comparing the severe acute respiratory syndrome as a result of COVID-19 infection to the previous two outbreaks of SARS and MERS. This article actually indicates that the innate immune response is a critical factor for disease outcome. And you can see here in the scheme, the article proposed that the host immune response during SARS-CoV-2 infection results in a delayed innate immune response, and this is through interfering with type 1 interferon signaling. That lead to active replication of the virus, which is about 6.4 days in average as a duplicate time. Later, that results in hyperproduction of type 1 interferon response during the initial phase, a dramatic drop of the virus load that correlate with the development of the initial symptoms will occur. And that actually led to another speculation of why some patients might have negative results at the beginning. Later, a pro-inflammatory cytokines and a cytokine storm from the hyperinflammatory response by the innate immunity will lead to sepsis, inflammatory induced lung injury, as you see here, and pneumonitis/alveolitis. And there's also another theory about possible HLH as a result. So in summary, actually, the severity of the disease depends on how suppressed is the innate immunity, specifically type 1 interferon immune response due to the virus at the beginning. Individuals susceptible are those with comorbidities as diabetes and cardiovascular diseases, and that might explain why a lower number of severe cases among children was reported actually, as kids tend to have very effective type 1 interferon response. This is a retrospective multicenter cohort study that included all adult inpatients with laboratory confirmed COVID-19 in Wuhan, China, who had been discharged or had died by January 31st of this year. And you can see here in the figure, among non-survivors, the median time from illness onset was 12 days to ARDS. Compared to 10 days for those who survived. Another study came out of China, Wuhan, China, with a focus on identifying clinical predictors of mortality due to COVID-19, mainly to effectively prioritize resources for patients with highest risk. In this figure, we see a summary of the cause of death of 68 died patients, which equate to 45% of the study population with confirmed COVID-19, and 53% of them died mainly from respiratory failure, while 33% of them died from a combination of respiratory failure and myocardial damage. defined as rising troponin in the setting of rapidly progressing hypotension, thought to be due to fulminant myocarditis. And 5 patients only died from myocardial damage without any evidence of or preceded respiratory failure. And from the total study population, we see about 20% of the patients actually were admitted to the ICU, and almost close to 90% of those patients actually were intubated. This retrospective study, which was published in New England Journal early in March of this year, provides more representative data, as the study included 1,099 patients with positive COVID-19 from 552 hospitals in 30 different provinces in the time between December of 2019 to January 29th of 2020. And we can see here only 5% of the patients were admitted to the ICU. About 3.4% of the patients had or carried a diagnosis of ARDS, and 2.3% actually needed invasive mechanical ventilation. And unfortunately, 1.4% of the patients died. And based on data reported by the National Health Commission of China as of February 10th of 2020, only 6% needed a non-invasive or invasive ventilatory support. This number is consistent with most of the reports that came out of China over the last month. Until the crisis, there were about 300 ICU physicians and 1,000 ICU nurses in Wuhan City. By the end of January, more than 600 additional ICU doctors and 1,500 ICU nurses were transferred to Wuhan from the rest of China. Wuhan City had the highest mortality rate, almost close to 4%, followed by other cities in Hubei province, which remain at 1.4%. Many factors contributed to the higher mortality in Wuhan City. The limited resources, suboptimal triage system, and lack of intensivists in some of the centers led to many severe hypoxemic patients to only receive high flow nasal oxygen or non-invasive mechanical ventilation rather than invasive mechanical ventilation. And among those who were intubated, low compliance with lung protective ventilation strategy and lack of standardized sedation and paralysis strategies contributed to the poor outcome per the article. As COVID-19 became pandemic, we started to learn more about the clinical characteristics of the disease, but more importantly, we started to see variations in the disease outcome between the countries. For example, Italy recorded the highest mortality rate, which is up to 7.5%. And more importantly for us, as the intensivists who are managing critically ill patients, we see 5 to 10% require ICU admission, which is close to the number came out of China's studies. Moving from Italy to the United States, one of the earliest data came out of ICU at Evergreen Hospital in Washington State between February 20th and March 5th. 21 critically ill patients were positive with COVID-19. 71% of them were intubated, and almost 100% due to ARDS, and 33% of them developed cardiomyopathy, which is very interestingly similar to the data came out of Wuhan, as I discussed earlier in this presentation. Although 67% of those patients were actually, unfortunately, died, but it's hard to make a conclusion given the low number of cases and the data that came out of a single center. But at least these data these data did alarm the U.S. Healthcare system in order to start to prepare for the rising number of cases in the United States. Next. The CDC just released its morbidity and mortality report, and as we see in this table, up to 11.5% of the patients required ICU admissions. The case fatality rate ranged between 1.8 to 3.4%, and 80% of the deaths were among patients 65 years or older. So the most important question at this stage, how can we predict which group of patients will have develop a worse outcome? Based on a literature review through mid-March of 2020, a number of factors were observed which can predict severe phenotypes of the disease. Among the list of factors, older age is the main risk factor for death in multivariate analysis. Other factors like elevated CRP more than 8, high rising troponin, very high rising LDH, and elevated D-dimer can predict cardiomyopathy and worsening ARDS. But definitely, one of the earliest clues that was found to also predict worse outcome is lymphopenia, and upper lobes involvement on CT scan, in addition to development of multi-organ failure. Other questions that we might not have answers for yet include: are we dealing with a more virulent virus? Is COVID ARDS clinically different from non-COVID ARDS? Is the variation in mortality rate between countries due to better preparedness, or is it because some countries have older population, as Italy, for example? Or is it because of practice variations in the management of severe cases? Until we have more answers, we should stick to the basics, especially when it comes to the management of critically ill patients, and more specific, patients with COVID ARDS. We have to prepare our ICUs to handle the surge of patients with COVID-19, because at the end of the day, this virus causes ARDS, which we know how to manage based on years of strong evidence of data that have been validated over the last 2 decades. It's important to identify the biomarkers that can predict severity and outcome in patients with COVID-19, and it's also important to focus on the high-risk population, from previous data, male older than 60 years with comorbidities, and also to implement the standard protocols and therapy for management of severe cases, which include ARDS, and also to focus on the public health measures that can slow the progression and the spread of the infection. So given that most of the mortality from COVID-19 seems to be related to severe ARDS, in the next 30 to 45 minutes, I will be reviewing the basics of ARDS and highlight the evidence-based management of mild to moderate ARDS, and also we'll talk about how to approach refractory hypoxemia in moderate to severe ARDS. Next. So the question is, what is ARDS? Many of us are familiar with the term ARDS, which is basically a patient with acute hypoxemic respiratory failure due to non-cardiogenic protein-enriched pulmonary edema. The most common clinical disorder is pneumonia, but second is non-pulmonary sepsis, aspiration, and trauma. The pathogenesis of lung injury involves injury to the endothelial vascular barrier first, even if the primary insult is pneumonia, and then breakdown in the epithelial barrier. Together, these effects result in endothelial and epithelial permeability, which further facilitate the transmigration of neutrophils, platelets, and extracellular traps, in addition to other cells like lymphocytes. And this will lead to the influx of edematous fluid and RBCs. The airspace filling with edematous fluid causes atelectasis, which in result lead to a shunt physiology that causes hypoxemia. The inability for efficient gas exchange lead to hypercapnia, which increase the pulmonary dead space. In ARDS, as a clinician, we know that the non-pulmonary organ failure and comorbidities contribute to a higher mortality. Next. So why it's important to review the definition of ARDS? The LungSafe study, which was published in 2016, revealed that ARDS is under-recognized and under-treated, given that only 51% of the clinicians were able to recognize mild ARDS, and 79% of them were able to recognize severe ARDS. Clinicians' compliance to lung protective strategy, which is very important in the management of ARDS, was also low, less than 65%. Next. ARDS was initially defined in 1967 with a case-based report that described the clinical presentation in critically ill adults and children of acute hypoxemia with non-cardiogenic pulmonary edema, reduced lung compliance, increased work of breathing, and the need for positive pressure ventilation. In 1992, an American European consensus conference established specific diagnostic criteria for the syndrome. These criteria were updated in 2012 in the so-called Berlin definition of ARDS in adults. As we see here, it requires respiratory failure to happen within 1 week, not fully explained by cardiac function or volume overload. That results usually in bilateral pulmonary, non-cardiogenic pulmonary edema, represented and manifested as bilateral opacities, either on chest X-ray or CT scan. And the onset of hypoxemia defined by PF ratio, which is PaO2 from arterial blood gas over the FiO2 less than 300 millimeter mercury, with at least PEEP of 5 centimeter water. If the PF ratio is between 200 to 300, then it is mild disease. If it is between 100 to 200, then it's moderate ARDS. And if it's below 100, then it's a severe ARDS. The reason why the Berlin definition replaced the old definition, mainly because it has better prediction of mortality, which can go up to 45% in severe cases, as we see here, based on meta-analysis that included 4,000 patients. But we should take this with a grain of salt. As we see here, the area of under the curve is still poor, only 0.577 compared to the previous definition of 0.536. In 2016, a group from Kigali tried to modify the Berlin diagnostic criteria in order to examine the incidence and outcomes of ARDS in low-income countries with limited resources. They did not require a PEEP of 5 in their definition, with hypoxia cutoff slightly higher, less than or equal to 315 millimeter mercury compared to the Berlin definition. Although the Kigali modification can provide a promising alternative and practical way to identify ARDS, especially for those who are not intubated, but without validation, it's really hard to adopt and use it in a wide scale. So for now, we are still using the 2012 Berlin definition. Next. As we see here on the chest X-ray of a patient with ARDS that shows bilateral opacities, and on the CT scan we can see bibasilar consolidation, especially on the left side or the left basis, compared in the background of ground glass opacities. Next. Diffuse alveolar damage is considered the histological hallmark for the acute phase of ARDS, and that was well established since 1976. It was also proposed around the same time that ARDS progressed and evolved through three phases, major phases: executive phase, proliferative phase, and fibrosis versus resolution, and it depends on the persistence of the lung injury and insult. However, the chronology of these phases was not accurately defined or well established. In 2013, Phil and his group published the first study that aimed to determine the time to onset of executive or proliferative changes and end-stage fibrosis in ARDS. They analyzed 159 autopsies from patients who presented with histological finding of diffuse alveolar damage at autopsy examination and met at the same time the clinical criteria for diagnosis of ARDS at the time of death. The criteria for diffuse alveolar damage were the presence of hyaline membranes plus at least one of the following, which include edema, cell necrosis, or proliferation, or fibrosis. As we see here in this figure, within the first week of evolution, the executive changes were predominant, and fibrosis was rarely noted. Beyond the third week of evolution, the proliferative changes were noted in all patients and fibrosis in just 2/3 of them. Next. For a long time, experts and clinicians considered the presence of DAD is the only histopathological findings in patients with ARDS. Despite that, getting tissue diagnosis was not considered as mandatory given the difficulties to obtain biopsy for all patients with ARDS. For that reason, clinical variables and criteria were developed over the years to identify patients with ARDS, as we discussed in the previous slides. So the question, does every patient with ARDS have DAD on biopsy? This study that was published in the American Journal of Respiratory and Critical Care Medicine in 2013 provides 20 years of postmortem pathology data from patients with ARDS. As we see here, among patients who met the Berlin criteria for ARDS, only 45% of them found to have DAD, compared to the remaining, which about 55% found to have alveolitis consistent with acute pneumonia. It also shows that the incidence of DAD declined in the low tidal volume era, which is the second half of the study between 2000 and 2010. Also, it confirms and shows that DAD findings were correlated with severity and duration of ARDS. Patients with DAD found to have more severe form of ARDS, either moderate or severe ARDS. Another study that was published in Chest Journal in 2016 revealed that patients with DAD and ARDS, they have higher mortality. Next. My takeaway message from this section, regardless of the pathobiology and the mechanism of injury in ARDS, the first 7 days provides a critical window for potential therapeutic intervention, mainly before the evolution of ARDS toward proliferative or fibrosis phase. Also, not all patients with ARDS will develop DAD. ARDS and DAD associate with poor outcome, as we discussed in the previous slides. It correlates with severe clinical profile and associated with higher mortality. At present, the Berlin definition has been adopted by most critical care societies around the world, as it requires 1 week of respiratory failure with non-cardiogenic pulmonary edema, plus bilateral opacities on chest X-ray or CT, plus PF ratio and hypoxemia with PF ratio less than 300 millimeter mercury in the presence of 5 of PEEP. In the next few slides, I will be discussing and highlighting the treatment of mild to moderate ARDS. I will start initially with highlighting the new and recently published WHO guidelines and compare that to the standard of care based on hallmark studies that were published in the last decade and helped us to define the appropriate strategic plan and treatment for ARDS patients. Next. In mid-March of 2020, the WHO released the clinical management guidelines of severe acute respiratory infection when COVID-19 is suspected. And for those who don't require mechanical invasive ventilation, we start with oxygen therapy. Usually we start with the standard oxygen therapy, either a nasal cannula oxygen or a face mask. And if the patient still require a higher oxygen concentration in order to achieve normal saturation, which is above 92%, then we can think of using high flow nasal cannula oxygen. And in special occasions, we can use non-invasive mechanical ventilation like BiPAP or CPAP, which usually we reserve for those who have chronic hypercapnic respiratory failure at baseline, like COPD patients, for example. And because of the uncertainty around the potential for aerosolization of the high flow oxygen and non-invasive ventilation, including the bubble CPAP, which is not common in Sudan and more common in Europe, we should use them with airborne precautions until we rule out those patients. And patients who are treated with either a high flow nasal cannula oxygen or non-invasive ventilation should be closely monitored for clinical deterioration and need for endotracheal intubation. Compared with the standard oxygen therapy, from previous study, we know that high flow nasal cannula reduced the need for intubation, which is also recommended by the WHO in the recent guidelines. Next. One of the hallmark study that studied the use of oxygen therapy in early ARDS is the Florali study. It was an RCT, randomized clinical trial that included 313 patients and divided them into 3 groups: a group with the standard oxygen therapy, nasal cannula and face mask, versus high flow nasal cannula oxygen compared to non-invasive ventilation therapy. In their study, they excluded hypercapnia and the use of vasopressors and glycoma scale below 13. And as we see here, the most common diagnoses for early ARDS was community-acquired pneumonia, followed by hospital-acquired pneumonia. Although we have a clear evidence that the high flow oxygen group had less intubation rate compared to non-invasive, but the difference was not significant, as we see here. But the superiority of the high flow over the non-invasive came from the mortality benefit of using high flow, 90-day mortality benefits of using high flow over the non-invasive ventilation as well. So the question for now is that due to the high tidal volume that the non-invasive ventilation provides during the acute phase of the ARDS? At this point, it's hard to answer this question, but at least we have some evidence that came out of the Floral study that using high flow oxygen followed by the standard oxygen are superior to the use of non-invasive ventilation based on the 90-day survival benefits. Next. When it comes to invasive mechanical ventilation management and moderate to severe ARDS management, the WHO recommend to intubate those patients with the most expert provider and to implement lung protective ventilation and to prone ventilate those patients early in the process for severe ARDS for 12 to 16 hours per day, and to follow a conservative fluid management strategy, and in patients with moderate to severe ARDS to use higher PEEP, which there's some data coming from Italy and also from China that actually suggested against that, but we'll discuss that later. And in moderate to severe ARDS, not to use routinely neuromuscular blockade, and to consider ECMO in refractory hypoxemia. All these strategies that's been published and suggested by the WHO are actually in alignment with the standard of care of ARDS that the critical care community developed based on hallmark studies and evidence-based guidelines that I will highlight in that I'm going to highlight in my next coming slides. Next. For many years, the standard therapy with mechanical ventilation support included high tidal volumes in ARDS, and here we're talking about 12 to 15 ml per kg ideal body weight. The potential contribution of high tidal volumes and elevated airway pressures that worsen the acute lung injury was concluded to be due to ventilatory-induced acute lung injury, or VALI, which was well studied by the ARMA trial in 2000. And it shows that lower tidal volume and limited airway pressure markedly reduce mortality in patients with ARDS, as I will discuss later. Here, in this slide, we see the compliance curve and the two common valley zones, or the two common injury zones that induced by the ventilation include the overdistension zone as a result of high tidal volume, which put the patient at risk of polytrauma or barotrauma. The other zone is the de-recruitment zone, where low PEEP can lead to atelectotrauma or more atelectasis. So the goal from our mechanical ventilation strategy is to avoid those two zones by applying low tidal volume and optimize the PEEP. Next. Another way to explain these three zones to look at the cross-sectional cut of the lung in a patient with ARDS. And we see here zone 1 revealed a dry lung where the patient or the lung at risk of overinflation, and the patient at risk, as a result, the patient at risk of polytrauma, and because of that, the best strategy is to keep the plateau pressure below 30 by using a low tidal volume strategy. Zone 2, or what we call it also the wet zone, and you can see here on the CT scan the background ground glass opacity that most likely indicate pulmonary edema. And at this zone, this zone actually is PEEP recruitable, but if you use higher PEEP, you will put the patient at risk of barotrauma. For that reason, optimal PEEP is very important to recruit the zone. Last, zone 3, usually at the basis, and as we see here in the CT scan, it's consolidation and reflect collapsed lung, and usually this patient and this part of the lung is at risk of atelectotrauma due to low PEEP, But other strategy that we can use to recruit this part of the lung is through prone ventilation, recruitment maneuvers, or using of liquid ventilation, like inhaled nitric oxide, as I will discuss in details in the coming slides. Next. To be more inclusive, let's summarize and review the basic strategies for management in ARDS. Number one, the main goal is to increase the mean airway oxygenation, and this is through maximize FiO2 and increase PEEP. Second, minimize heterogeneity in the lung, and we can use to achieve this goal is we can use paralysis and proning. Increase perfusion to ventilated lung. Best strategy to achieve this goal is to use inhaled nitric oxide. Minimize trauma, and we discussed that in the previous two slides. And here we're talking about like baro, atelecto, or volley trauma. And the strategy to achieve this goal is by using low tidal volume ventilation, specifically 6 to 8 ml per kg, lower plateau pressure, lower than 30, and to minimize the peak pressure. And last is to promote healing through reabsorption of alveolar fluid. And again, strategies like low tidal volume can also help, but more importantly, to minimize excess fluid and to prevent also infection. Next. So in order to hasten the development of effective therapy for ARDS, the National Heart, Lung, and Blood Institutes, the NHLBI, part of the National Institute of Health, NIH, in the US, initiated a clinical network to carry out multi-center clinical trials of ARDS treatment. That was back in 1994. The goal of the network was to efficiently test promising agents, devices, or management strategies to improve the care of patients with ARDS. During its 20 years, 5,527 patients were enrolled in 10 different randomized controlled trials and one observational study. The most influential trials that helped to develop and shape the current guidelines of conventional management of ARDS include, as we see here in this timeline, the lower tidal volume trial, the ARMA trial, the higher versus lower PEEP trial, the alveoli trial, and the fluid and catheter treatment trial, the FACT trial. Next. The lower tidal volume trial, or the ARMA trial, it was a randomized controlled trial, multi-center, enrolled 861 participants, and the goal of the trial was to compare the traditional high tidal volume used for managing ARDS to lower tidal volume ventilation. As a result of the trial, the Critical Care Society, adopted the lung protective ventilation, which include low tidal volume less than 6 ml per kg ideal body weight, with the goal to keep the plateau pressure less than 30 centimeter water, and allow permissive hypercapnia as a result of this as low as 7.20, and use optimized or adequate PEEP. As we see here in this summary of ventilator procedures that have been used in the study, that the lower tidal volume groups used a tidal volume of 6 ml per kg, and they kept their plateau pressure below 30 compared to 12 ml per kg tidal volume and plateau pressure, a higher plateau pressure lower than 50. Otherwise, the remaining variables were comparable. Next. Clearly, we can see here the 6 months mortality benefit from using a low tidal volume strategy. Again, in patients with ARDS, mechanical ventilation with a lower tidal volume versus high tidal volume results in decreased mortality, as we see here in this table, but more importantly, it also increases the number the number of days without ventilatory support. Next. In this slide is a review of the ARDS protocol and a summary of the lung protective ventilation for patients with ARDS, defined as acute hypoxemic respiratory failure with PF ratio less or equal to 300, in the presence of bilateral infiltrate consistent with pulmonary edema, without any evidence of left atrial hypertension or left side heart failure. It's very important to be very systematic in management of ARDS. So as number one, or part one, to start with setting up your ventilator, and it will give you also a guideline on how to adjust the tidal volume and respiratory rate based on the goal that we're trying to achieve based on the ARDS protocol. So number one, it's very important to calculate the ideal body weight, as we see here, or the predicted ideal body weight, as we see here from the equation for males and females. Number two, you select any ventilatory mode, but according to the ARMA trial, the mode that was used in the trial was a controlled volume mode, or volume control mode. The goal is to set and achieve a total volume of 6 ml per kg in the first 2 hours. You can either decrease or increase your total volume by 1 ml per kg based on your ABG. You set up also the initial rate to approximate baseline minute ventilation. Make sure that you don't exceed 35 breaths per minute. And also, if you have a patient with COPD or asthma, in order to avoid dynamic hyperinflation, you have to be very careful with the rates. So it is always recommended to use a lower rate at the beginning. And here I'm talking about lower than 20. Next, you always adjust your tidal volume and respiratory rate to achieve pH goal of more than 7.2, and always remember that your goal is to keep your pH, to allow permissive hypercapnia, but to keep your pH above 7.2. And also you adjust your tidal volume and respiratory rate to achieve plateau pressure below 30. You check your plateau pressure by applying inspiratory pause for 3 to 5 seconds, and you can check your plateau pressure every 4 hours and after each change in your PEEP or your tidal volume. If your plateau pressure is more than 30, then you decrease your tidal volume by 1 ml per kg. Minimum tidal volume that you use in ARDS protocol is 4 ml per kg. And if your plateau pressure is below 25 and your tidal volume is actually below 6 ml per kg, then your goal is to go back to 6 ml per kg to keep as long as you are achieving a plateau pressure less than 30. More important, if the plateau pressure is less than 30 and the patient is having breath stacking or desynchronous with the vent, then you still have room to increase your tidal volume by 1 ml per kg in order to see if that will help to elevate the breath stacking or the desynchrony. But please don't forget or don't exceed 7 or 8 ml per kg as long as the plateau pressure below 30. The last goal that you are trying to achieve in your ARDS protocol is your oxygenation goal, which is PaO2 between 55 to 80 or saturation between 88 to 95%. I will defer the talk about how to set up your PEEP for future slides. Next. Low tidal volume ventilation, overall generally well tolerated, but there are always potential adverse effects. As we mentioned in the previous slides, in the summary of ARDS protocol, permissive hypercapnia is allowed in low tidal volume ventilation as long as the pH is above 7.2. But if the acidosis becomes an issue, respiratory acidosis becomes an issue, then adjusting the respiratory rate as well as the tidal volume can be very helpful, as I discussed in the previous slide, as long as we are not inducing an auto PEEP. The second most common adverse effects from using low tidal volume ventilation is auto PEEP. There are two strategies to minimize auto PEEP, either by reducing the total minimum ventilation, by decreasing the respiratory rate or the tidal volume, or both. And the other way to do it also is to decrease the IE ratio by raising the inspiratory flow rate. Next. The second hallmark trial in ARDS is the FACT trial. The FACT trial, which is an RCT that enrolled 1,000 patients and compared conservative versus liberal strategy of fluid management in ARDS patients. Although there was no significant difference in the primary outcome of 60-day mortality, the conservative strategy of fluid management improved lung function and shortened the duration of mechanical ventilation and intensive care without increasing non-pulmonary organ failures. So in summary, the conventional management of ARDS include lung protective ventilation, and more specifically to use a low tidal volume of 6 ml per kg ideal body weight, and to target plateau pressure less than 30 centimeter of water, and allow permissive hypercapnia of more than as low as 7.2 or above, and to avoid high peak pressure. The second strategy is to apply a conservative fluid management, and by this I mean to run the patient even with even I's and O's, or negative 500 to a liter ml per day. The third strategy is to use a reasonable amount of PEEP and the lowest FiO2 that will achieve the oxygenation goal. Next. In the next 10 to 15 minutes, I will be reviewing how to approach and manage patients with refractory hypoxemia in ARDS. Next. Refractory hypoxemia is considered if the PF ratio is lower than 100, or if it's higher with inability to maintain plateau pressure lower than 30, despite lowering the tidal volume to the lower limit of 4 ml per kg, or if the patient develops barotrauma. Also, another way to identify refractory hypoxemia is by calculating the oxygen index. Oxygen index higher than 30 usually indicates refractory hypoxemia. As we see here in the equation, the oxygen index incorporates both severity of hypoxemia and which is the PF ratio, and means airway pressure into a single variable. The oxygen index has been found to be useful in patients with ARDS, as it can independently predict mortality. Also, in a post-hoc analysis of the Berlin study, 2 physiological measures were used in addition to the PF ratio lower than 100 in order to identify high-risk subgroups among patients with severe hypoxemic ARDS. Number one, they used lower respiratory compliance, and number two, and because it was very challenging to calculate the dead space, they used a surrogate for this space by standardizing the minute ventilation at a PaCO2 of 40 millimeter mercury, which will calculate the corrected minute ventilation. So by combining a PF ratio of 100 millimeter mercury or less with either a compliance of 20 ml centimeter water or less, or corrected minute ventilation of at least 13 liter per minute, the mortality was found to be 52% for this high-risk subgroup with refractory hypoxemia compared to 37% without either high-risk predictors. Next. Actually, before I move to the next slide, I want to highlight that the high ventilatory requirements is defined as FiO2 if the patient is on FiO2 more than 70% and PEEP more than 15, or if the plateau pressure is above 30 with tidal volume less than 6 ml per kg. And if the patient developed very severe hypoxemic respiratory failure with a PF ratio less than 60, then we can consider ECMO. Next. Strategies that can be used in management of severe hypoxemic respiratory failure in ARDS include ventilator related strategies and non-vent related strategies. And if you see here, I put both higher PEEP and conservative fluid in italic, mainly because those two strategies can be used as part of the conventional treatment. But adding or trying recruitment maneuvers or switching from volume control ventilation mode for ventilation into pressure control or APRV or also called airway pressure release ventilation can be also reasonable, as long as you we're able to maintain lung protective ventilation. Other strategies like neuromuscular blockade, vasoactive therapies like inhaled prostacyclin or nitric oxide, trying prone positioning ventilation, or even as a last resort, ECMO can be also used here. Next. PEEP is a key element of protective ventilation and is routinely applied in all patients with ARDS, mainly to facilitate adequate oxygenation and maintain alveolar recruitment, which can reduce shunt physiology and improve oxygenation. But unfortunately, to date, no multicenter clinical trials have definitively shown that any one PEEP titration strategy provides superior patient-centered outcomes. So let's review the general rules that we have to remember every time we decide to apply PEEP for patients with ARDS. Overall, PEEP of 8 to 15 is appropriate in most patients. Always remember, oxygen goal is PaO2 of 55 to 80 millimeter mercury or SpO2 saturation of 88 to 95%. We try to reserve higher PEEP to those patients whom potential for recruitment is demonstrated. Also, we have to always avoid overdistension / barotrauma and hypotension. Also remember that PEEP over 24 is rarely indicated. Next. However, in 2010, a meta-analysis was published that included 3 major trials: alveoli from 2004, LOVES trial, and EXPRESS trials, and found that in patients with ARDS, there was a survival benefit in the higher PEEP group. Next. In order to determine the appropriate PEEP for your patient, it's always a good strategy to see the impact of the chosen PEEP on oxygenation, hypoxia, hypercapnia, and also to ensure a stable plateau pressure. to ensure compliance to lung protective ventilation. You can start with increasing the PEEP for 30 minutes and look for increase in oxygenation or increase in PaO2. Also looking for a decrease or stable plateau pressure. And third will be decreased or stable PaCO2. So if there's minimal improvement or worsening in the oxygenation or increase in the PaCO in the hypercapnia, which indicates increase in the dead space, or increase in the plateau pressure, which also indicate a decrease in the compliance, that will indicate no benefits for increasing the PEEP for that patient. Or another strategy, you can use a decremental trial starting with a higher PEEP at 20 centimeter water and lower every 30 minutes to see the impact as well. Once you determine what is the highest PEEP that can be used, then you can place the patient on the grid from the ARDS protocol, as we see here, mainly to guide you in how to come down in the PEEP and FiO2 based on the patient's needs. As you see here, you can choose between the lower PEEP, higher FiO2 strategy versus the higher PEEP / lower FiO2 strategy. As you see here, both strategies will start with FiO2 of 100%. And at least PEEP of 18 if you decide to choose the lower PEEP, higher FiO2 strategy, or PEEP of 22 if you decide to choose higher PEEP, lower FiO2 strategy. The difference between the two, that in the lower PEEP, higher FiO2 arm, you should come off the PEEP faster compared to the higher PEEP, lower FiO2 arm. For example, say reach FiO2 of 50% and PEEP of 10. But if you want to compare that to the higher PEEP, lower FiO2 arm, then by the time you reach the FiO2 50%, your PEEP is still 18 compared to the 10 in the lower PEEP, higher FiO2 arm. Next. Another way to adjust the PEEP is by measuring the stress index. The stress index provides a non-invasive approach to detect volume trauma or atelective trauma. From previous experiments in porcine acute lung injury model showed that on a stress index lower than 0.9 indicate recruitability, and a stress index more than 1.1 indicate overdistension. But obtaining the stress index can be very challenging, as it requires quantitative measures to analyze the shape of the pressure time curve. Sun and his group in 2018 actually, introduced a method for estimating the stress index at the bedside by visually inspecting the waveforms on the ventilator screen with sensitivity of 92% and specificity of 94%. As we see here in the diagram, downward concavity on the pressure volume on the pressure time curve correlate with the stress index more than 1.1, which can indicate overdistension. So and perhaps decreased PEEP might help in this situation. On the other hand, upward concavity correlate with stress index less than 0.9, which indicate recruitability, and using a higher PEEP might be helpful in this situation. Next. Also, another way to adjust your PEEP is by using esophageal pressure monitor, which can be used in patients with decreased chest wall compliance due to pleural effusion, morbid obesity, or abdominal compartment syndrome, for example, as airway pressure alone may be insufficient to guide lung protective PEEP titration in those patients with ARDS. The chest wall and abdomen contribute an predictably to pleural pressure and respiratory system mechanics in the critically ill patients. Distinguishing lung from chest wall mechanics requires to consider calculating for transpulmonary pressure, which equal airway pressure minus the pleural pressure. The ventilator can measure the airway pressure for you, while pleural pressure can be estimated via the esophageal manometry using a balloon catheter positioned in the mid-thoracic esophagus. Although the initial data from a single center study included 160 patients was promising for the use of the esophageal manometer and esophageal pressure monitor, but the results from a follow-up multicenter RCT that was published in 2019 revealed that among patients with moderate to severe ARDS, esophageal pressure monitor guided PEEP compared with empirically high PEEP FiO2 resulted in non-significant difference in death and days free from mechanical ventilation. So these findings actually do not support the use of esophageal pressure monitor guided PEEP titration in ARDS. Next. Recruitment maneuvers can be another strategy to manage patients with severe or refractory hypoxemia in severe ARDS. Different strategy can be used, but the goal is to transiently increase the transpulmonary pressure to recruit alveoli and improve gas exchange. It can be used with volume control mode, and in this situation you will need to simultaneously decrease the total volume while you're increasing the PEEP to minimize the risk of overdistension, or it can be used also with pressure control mode plus PEEP titration. Next. The role of recruitment maneuvers in managing ARDS patients is uncertain at this time. In order to determine if lung recruitment with PEEP titration has a higher 28-day mortality of patients with moderate to severe ARDS compared with a conventional low PEEP strategy, in 2017, a multicenter RCT was conducted to answer that question. 1,010 patients with ARDS were included from 120 ICUs in 9 different countries. In the intervention group, neuromuscular blockade and pressure control plus PEEP were used as the lung recruitment strategy. As a result, the 28-day mortality was significantly higher among patients treated with strategy of lung recruitment and PEEP titration. It was about 55.3% than those treated with conventional low PEEP strategy, which was about 49.3%. Also, in the intervention group, there was higher risk of pneumothorax and barotrauma as well. So again, routine use of recruitment maneuvers are not recommended. Next. Another strategy that can be used in management of severe ARDS and refractory hypoxemia include neuromuscular blockade. Despite high doses of sedatives, an increased respiratory drive of ventilated patient with ARDS may result in severe patient ventilator desynchronies, and that can lead to increased mechanical lung injury, more specific polytrauma, barotrauma, or atelectasis trauma, as we see here in this figure. So using paralytic can prevent patient ventilator desynchrony and thus reduce the probability of ventilator-induced lung injury. And as a result, that can lead to improved oxygenation, improved chest wall compliance, decrease O2 consumption, and may also lower the pulmonary and systemic cytokines. Next. In a multicenter trial that included patients with severe ARDS, infusion with neuromuscular blockade agent cisatracorium within 48 hours revealed a 90-day survival benefit in patients with PF ratio less than 120. And also, it revealed that neuromuscular blockade agents group had significantly more vent-free days ICU-free days, less organ failure, less barotrauma compared with deep sedation without cisatracorium. Next. Despite these encouraging results, early neuromuscular blockade wasn't widely adopted, especially here in the US. A potential concern include the lack of research compared the neuromuscular blockade and deep sedation with the usual practice that promote for lighter sedation. To answer this question, a follow-up trial, the ROSE trial, was conducted in 2019 by the BTAL network of the NHLBI. Next. The ROSE trial is a multi-center unblinded RCT that included patients with moderate to severe ARDS, aimed mainly to compare the use of neuromuscular blockade and deep sedation earlier in the process compared to the usual practice that promote for lighter sedation. And to be consistent with the Acute trial, lung protective ventilation, higher PEEP, and conservative fluid management were used in both. As I discussed in my previous slides, that the Acute trial revealed a 90-day survival benefits from early use of cisatracorium in patients with moderate ARDS and PF ratio less than 150. In comparison to the ROSE trial that was conducted last year in 2019 and revealed no mortality benefits between the two groups. And matter of fact, also it showed that there is increased ICU acquired weakness and cardiovascular events in the neuromuscular blockade group. So the question, why there are discrepancy in the results between the Acute and the ROSE trials. Next. Some of the factors that might contribute to the discrepancy of the results between the two trials include that the ROSE trial was unblinded, but also 48% of the patients in the Acute trial were placed in prone position compared to only 16% of the patients in the ROSE trial. And as I will discuss in the upcoming slides, that proning ventilation or proning position, prone positioning can reduce mortality. So maybe that was some of the impact of the prone positioning in the Acute trial compared to the ROSE trial. What makes this justification possible is that there was a similar mortality in the control arms of both trials, in the Acute and also in the ROSE trials. Last, in the ROSE trial, the depth of the neuromuscular blockade was not measured with the train of 4, for example, and that will raise the question of how effective was the use of the neuromuscular blockade in the ROSE trial. At this point, it is very reasonable to consider the use of neuromuscular blockade within 48 hours of intubation for patients with moderate ARDS with PF ratio less than 150. Next. The rationale of using prone positioning in ARDS, that with proning, alveolar recruitment will improve by redistribution of ventilation to posterior lung, and that will eliminate the compression of the lungs by the heart, which will decrease the shunt physiology by decreasing the posterior atelectasis. Few complications were reported with prone positioning include a pressure sores, ET tube obstruction or extubation, loss of central venous line, and the need for heavier sedation. Since the 1980s, 4 randomized clinical trials and meta-analysis showed no survival benefit of prone positioning until the PROSEVA trial came out in 2013, where 466 patients with moderate ARDS were included in the trial and were prone within 36 hours of intubation. 27 prone experienced ICUs were involved, and the average proning time was 17 hours. 91% of the patients in the prone group were paralyzed. Next. And clearly here in the graph, we see the survival benefit, the 90-day survival benefit among the prone group. Next. So the great question at this moment is, can we prone non-ventilated ARDS patients, especially during the COVID-19 ARDS era? This is actually a study that was published early this year, January of 2020, that evaluated the efficacy and safety of early prone positioning combining with high flow nasal cannula or non-invasive ventilation in moderate to severe ARDS. It's a prospective observational cohort study in 2 teaching hospitals in China that included non-intubated moderate to severe ARDS patients, 20 patients between January of 2018 till April of 2019. The patients were placed in prone positioning with non-invasive ventilation or with high flow nasal cannula, and the efficacy in improving oxygenation with the 4 support methods, which are the high flow nasal cannula plus prone positioning, nasal non-invasive ventilation versus non-invasive ventilation plus prone positioning. All 4 support methods were evaluated by ABG, and the primary outcome was the rate of intubation. Secondary outcome was to evaluate the PF ratio improvement. They used the Berlin criteria for ARDS, where PF ratio lower than 200 on PEEP of 5 by using a non-invasive ventilation, CPAP or BiPAP. Then they will place the patient on high flow nasal on 5 of PEEP using a non-invasive ventilation on 50% FiO2 at least for 30 minutes. Next. This is the algorithm that they used in enrolling their patients to the study. After they diagnosed the patient using the CPAP or BiPAP with PEEP of 5, supported by FiO2 50% for at least 30 minutes, and after the ARDS being diagnosed, then they will include the patient to be monitored on non-invasive for a target of SAT of more than 90% with a FiO2 of 60%. And based on that, they will patients will be split into either place on high flow nasal cannula or to add prone positioning to the non-invasive immediately. As a result, 11 patients out of the 20 were not intubated, 55%, which is and 73% of them had moderate ARDS compared to 23% with severe ARDS. And if you compare the successful group or non-intubated group to the intubated group, we'll find there's like non-significant difference between the proportion of moderate ARDS, which was higher in the non-intubated group. Also, we see here, and when we compare the PF ratio of the patients in the success and failure groups with the 4 different support methods, you find here that using the high flow nasal cannula versus high flow nasal cannula and prone positioning revealed higher PF ratio, and it was significant compared to adding non-invasive to non-invasive with prone positioning. It was insignificant, but actually the PF ratio had dropped. So the question is, can we generalize these results? First of all, in this study, non-invasive ventilation was considered an escalation of care. And we know from previous studies, from the Florali study, that the high flow nasal cannula oxygen was superior when it comes to 90-day mortality. And although it didn't show significant difference in terms of the intubation rate, but it was clearly that the high flow nasal cannula oxygen group had less intubation compared to the non-invasive ventilation. The other thing also in this group, that the exclusion criteria that they used for hypercapnia was a little bit higher, where the PaCO2 here, the exclusion for PaCO2 was above 50, while in the Florali was above 45. And the small sample size in this study make it very difficult to differentiate between which one has a better, which one of the two mode of support between the high flow nasal cannula plus the prone positioning versus the non-invasive plus the prone positioning has actually better outcome. And definitely, we will need a multi-center perspective RCT in the future to evaluate non-intubated, to evaluate the need of proning use in non-intubated moderate ARDS patients before we reach a final conclusion. But at this time, and for now, I think we can consider early prone positioning plus high flow oxygen for patients with non-intubated moderate COVID ARDS with PF ratio between 100 to 200. Next. Another strategy in management of refractory hypoxemia in ARDS is the use of the vasoactive therapies. For example, using inhaled nitric oxide lead to selective vasodilatation of the ventilated pulmonary vessels, which will improve the VQ matching, oxygenation, and reduce the pulmonary artery pressures. Several RCTs and systemic review, in addition to meta-analysis, all demonstrated improvement in oxygenation, specifically improvement of the PF ratio within 24 hours, without improvement in mortality or ventilator free days or ICU length of stay. So the question is, can the high cost of the inhaled nitric oxide offset by fewer vent or ICU days? Usually the peak oxygenation effect reached at 20 ppm or less, with risk of acute kidney injury or methemoglobinemia at 80. Another agent also is the inhaled prostacyclin, which is another selective pulmonary vasodilator. It has a lower cost and can be used alternative to inhaled nitric oxide. In general, we also should avoid any systemic vasodilators like nitroprusside or hydralazine or nitroglycerin in patients with ARDS, because it might increase the intrapulmonary shunt and result in worsening hypoxemia. Regarding the use of albuterol in patients with ARDS, no impact on mortality or vent-free days in one clinical trials. Next. Other strategies in managing patients with severe ARDS is to use other vent modes like pressure control ventilation, where you target a steady and constant pressure, but at the same time you lose the control on the tidal volume, and that might lead to violation in the low tidal volume / lung protective ventilation, especially if the patient is actively breathing. But sometimes we are forced to use this mode, especially if you would like to achieve a better patient-vent synchrony despite being on heavy sedation due to higher peak inspiratory pressure. Also, we use pressure control ventilation, as I discussed in previous slides, in recruitment maneuver as part of the strategy to provide lung recruitment maneuvers. Overall, pressure control ventilation can provide better gas exchange and higher mean airway pressure. But again, it's not recommended to be first line for lung protective ventilation because you don't have you don't have a good control on the tidal volume. Next. Another mode is to use the same pressure control mode but with inverse ratio ventilation, where you set inspiratory time to be longer than the expiratory time. That can result in higher mean airway pressures that will improve oxygenation. The downside for using this mode is that it requires heavy sedation and paralysis, and may compromise hemodynamics and lead to auto PEEP. But overall, we still don't have any proven benefits of using this mode in ARDS. Next. Another uncommon vent mode that can be used during refractory hypoxemia is the APRV, or the airway pressure release ventilation, where the ventilator machine provides two different levels of airway pressure, high and low, or we call it also CPAP phase and relief phase. During the CPAP phase, the P high is the upper PEEP or CPAP level, and it's analogous to mean airway pressure, and thus improve oxygenation by maintaining high mean airway pressure for the inspiratory time, which occupy 80 to 95% of the respiratory cycle. Other benefits of this mode is that it will allow the patient to breathe spontaneously at this level during the CPAP phase or at any time of the respiratory cycle, which will improve the tolerability of the patient to the vent, and also will decrease the need for sedation and paralysis. But overall, there is no proven, or there are no proven benefits of using APRV in ARDS. Next. Although the EOLA trial in 2018 concluded that among patients with very severe ARDS with PF ratio less than 60, there was no significant benefit of early ECMO within the first 7 days of intubation as compared with the strategy of conventional mechanical ventilation. But the caveat here is that 28% of the patients in the control group in this trial crossed over to ECMO for refractory hypoxemia. This crossover rate makes it difficult to draw definitive conclusion regarding the usefulness of ECMO for severe forms of ARDS. So, in general, ECMO, if all other measures fail to improve the oxygenation, and if the patient qualifies, then ECMO should be considered using the inclusion and exclusion criteria by the EOLA study. And we should focus mainly on the primary respiratory failure and exclude multi-organ failure and advanced age. Next. In this slide, I will be talking about the weaning process for patients with ARDS. As you know from previous studies, that pairing or combining a daily spontaneous awakening trial and a spontaneous breathing trial for patients who are qualified for those trials will provide better outcomes and 3 days of ventilation. For patients with ARDS, we can consider SBT and SAT if the FiO2 is 50% or less with a PEEP of 8 or less. And then we will perform the SAT, SBT for 30 minutes up to 2 hours, as long as the patient can tolerate the trials. We can think about extubating the patients if the PF ratio above 200 and if the FiO2 is less than 50%, with the PEEP less than 8% for at least 12 hours in consecutive days. And also we want to make sure that the patient also has adequate cough and gag reflexes. I usually use this mnemonics, which is called WEANS now, in order to screen for any obstacles that can impact the extubation process, and in order also to set up the patients for success. The most important items from this mnemonics will include that the W is for improvement in the work of breathing, and the S also to have less amount of secretions, and also you want to make sure that the patient is awake and is following commands, or at least able to follow simple commands. And more important, also you want to make sure, as I mentioned earlier, that the patient has like an adequate cough and gag reflexes as well. Other factors that can also play a role in preparing the patient for extubation include like to make sure that the patient's acid-base balance is not in the alkalic side, and you want to make sure that the patient has also a good nutrition status as well. Next. Other data point that can be helpful in making the decision for extubation is using the rapid shallow breathing index, RESPI, which is only applicable to patients that are clinically ready for weaning from the ventilator, and it's not meant to answer the question of whether the patient is ready for extubation. Rather, it helps to predict the outcome after extubation. It was originally conceived in a prospective observational study by Yang and his groups in 1991, who sought at that time to examine which indices based on a physiological measurement could be used to predict successful extubation in mechanically ventilated patients who are considered ready for liberation from the ventilator. They found that RESPI score to have a sensitivity of 97% and a specificity of 64%. In other words, the probability of having a positive RESPI, which is lower than 105, which I will explain in a minute, who were successfully extubated was 97%. And the probability of having a negative RESPI, which is above 105, in patients who were unsuccessfully extubated was 64%. And the way that you calculate for RESPI, you put the vent at a CPAP of 5 centimeter water, and you record the respiratory rate and the tidal volume after at least 1 minute. And this is the equation that you use. You divide the respiratory rate over the tidal volume in liters, and if the RESPI is 105 or lower, we consider this is a positive RESPI. And if it's above 105, we consider this is a negative RESPI. Again, clinicians can use the positive RESPI as an additional supporting data point for the decision to extubate. SBT option, or spontaneous breathing trial options, is to put the vent at pressure support of 0 to 7 and the PEEP of 5. That's the most common, or you can put the patient also on TPs, which actually we rarely use nowadays. And then you decide to terminate the trials if the patient develop any of the following: if the patient becomes tachypnic above 35 minutes, above 35 breaths per minute for at least 5 minutes, and if the patient SAT is below 90% or FiO2 sustained unsustained FiO2 below 50%, and if the patient becomes tachycardic or bradycardic significantly or develop new significant arrhythmias, or if the patient become hemodynamically stable in terms of blood pressure, systolic above 180 or below 90. That's considered. This is kind of a criteria for to terminate your trial. Or the most important thing also, sometimes the patient will remain hemodynamically stable, but they will develop significant increased anxiety or discomfort with the apheresis. All these are indications that the patient might fail extubation. So for that reason, for that reason you will terminate the trial, or actually you should terminate the trial. Next.
Let's summarize. Next.
So before I conclude my presentation, let's review if there's any other specific recommendation for management of severe COVID-19 ARDS. This is a recent review article that was published in Lancet in March of 2020. So in terms of the use of high flow, it's recommended, and because it might prevent or delay the need of intubation, as we know. Recommendation to use lung protective ventilation and to keep tidal volume at 6 ml per kg, not lower than 4 ml per kg, and to maintain plateau pressure below 30. In terms of the PEEP, to consider moderate to high level if needed, which is similar to the recommendations that we discussed also in details. Little value of using a recruitment maneuver, and honestly, data doesn't support the use of recruitment maneuver in ARDS in general, so I will try to avoid that here also as well. In terms of neuromuscular blockade, no specific recommendation for COVID-19, and neuromuscular blockade can be used for to achieve ventilator synchrony and to increase airway pressure and improve hypoxemia for patients with moderate ARDS with PF ratio lower than 120 and early in the process. And in terms of the prone positioning, actually few studies came out of China recommending proning patient for worsening hypoxemia and moderate ARDS with PF ratio lower than 150. No recommendation against the use of inhaled nitric oxide, but remember not to exceed 20 ppm or particle per millions. In terms of other strategy in managing patients with ARDS, still to aim for negative fluid balance between 0.5 to 1 liter per day, and to consider CRT for oliguric renal failure, and to manage acidosis, and also to maintain a negative fluid balance as well. For antibiotics, recommendation to use it for secondary bacterial infections. No recommendation to use glucocorticoid in COVID-19 patients with ARDS, and to consider ECMO with refractory hypoxemia and PF ratio less than 60 based on the EOLA trial. So as we see here, there's no significant change, or there are no significant changes from what we just learned during this presentation. Next. Other potential experimental treatment for COVID-19 ARDS include anti-IL-6 or IL-6 receptor blocker therapy, interleukin-1RA, and interferon beta. For example, tocilizumab, which is also already FDA approved to manage cytokine release syndrome in patients receiving CAR T-cell therapy. It was also approved in China in March of 2020 to be used for severe COVID-19 ARDS. And in the US, an ongoing phase 2 trial of sarilumab in patients with COVID-19 ARDS. Other options include the use of allogenic mesenchymal stromal cells, and given a good preclinical evidence for multiple mechanisms of benefits and safety profile, a favorable a favorable phase 2b trial still ongoing for ARDS management. And before I conclude this slide, the use of high-dose vitamin C showed reduced mortality benefit in a favorable phase 2 trial that was published in JAMA of 2019 before the era of COVID-19 outbreak. Next. This is a summary slide of how to approach patients with ARDS in general, and we can apply it also with patients with COVID-19 ARDS as well. You start with conventional management of ARDS that include lung protective ventilation with 6 ml per kg of predicted body weight of tidal volume, and to ensure plateau pressure lower than 30, and to maintain fluid balance between -500 to a liter per day, and to optimize PEEP with oxygenation target of PaO2 of 55 to 80. If the patient does have mild to moderate disease, then consider to continue ARDS-NET guidelines with potential weaning as the patient continue to improve. If the patient shows any evidence of severe hypoxemia or severe ARDS by PF ratio lower than 100, or if the higher than that, but with an inability to maintain plateau pressure lower than 30, or if the tidal volume is about 4 ml per kg, which is the lower limit, or if the oxygen index more than 30, then consider management of refractory hypoxemia. So let's start with the PEEP. First of all, you perform or you apply a PEEP trial or higher PEEP trial by increasing the PEEP by 5 to 10 centimeter water to a maximum of 20. And then you are looking for response by increasing the oxygenation, either SAT more than 5%, or decreasing the PaSO2, or increasing the compliance, as we discussed. And if the patient show response, then most likely this is a high recruitment potential. Then you can put the patient on the high PEEP or the high PEEP lower FiO2 grid, as we discussed in previous slides. If the patient is not if the lung is not recruitable, or based on the PEEP trial, consider ECMO if the PF ratio lower than 60. Other strategies that can be used before you go for ECMO definitely is to consider neuromuscular blockade for those with PF ratio less than 120, and it's important to consider to start early neuromuscular blockade within the first 48 hours, for about 48 hours. Other option also is proning, and actually proning positioning, as we discussed earlier, provide very strong data if it's being used within the first 36 hours, and for an average time of 16 hours per day. Other options also to use inhaled vasodilator, like inhaled prostacyclin or inhaled nitric oxide. If you used one of the three options, you are looking for improvement of PF ratio by 20%. If yes, then you'll continue this therapy, or either combining or adding the three of them at the same time. If no improvement, then you should consider ECMO if the PF ratio lower than 60. I hope. Next. At the end, I would like to thank you for your patience and I hope I was able to provide you a valuable review of ARDS management. Everyone should start to look and prepare their own local ICUs to make sure which of the approved and recommended managements can be applied for your patients. Also, please make sure to use appropriate protective measures when you deal with patients who are infected or suspected to have COVID-19. Please also make sure to support your local communities and participate in the education about the disease and help to fight against stigmatization of patients who are infected with COVID-19. I wish everyone safe time during this outbreak. Thank you. Wassalamu alaikum.